Morning, everybody, and thanks so much for this opportunity. And I'm part of the MDT that set this up, so I'm really grateful for the opportunity to be one of the speakers as well. The tragedy of Hamlet, King of Denmark, the longest of Shakespeare's plays, by the way. He gets depressed and he has bipolar because in most of the time because he's got his Claudius, his uncle, kills his father so he can marry his mother and become king as head of the throne. But I'm not bringing that up for madness, except that a lot of what I'm going to be talking about is a bit schizophrenic, which is what he was not. You'll see that I've already put perioperative. That's because it's not only just about perioperative, it's also about radiation as well a little bit. My disclosures, I'm a stolen slide from you as usual, but I think you've got more disclosures than me. I'm going to cover a little bit of stuff. I'm not going to take too much time, hopefully, but we're going to be going through everything about muscle-invasive bladder cancer, from what the diagnosis, how it's going to impact on how you treat the patients, staging, the treatment itself, and then also surveillance. This is where we are at the moment. We look at cytology, which we know is not that great. Simon's not here at the moment, so we won't go. Chest X-ray, abdominal, pelvis to look for muscle invasion, which is not great, although the radiomics are improving. And then we do cystoscopies and we do a TURBT. And we're not doing enough. It's not as effective as we'd like to be. First of all, when it comes to TURBT, we're pretty good at looking, apparently, at bladders and making a decision on whether this is muscle invasive, whether it's high grade and that sort of thing. But the reality is that we still are not that great at doing this as well. Partly because we think TURBT as urologists is a Mickey Mouse operation. It's not. It's a big operation. It's not just to remove a bit of tissue and see what's going on. We have to, it influences on our management. If you look to triple therapy particularly, it's going to be a bit developing procedure. You can get a more precise histological evaluation. Carcinoma in situ, possibly. We don't use blue light here yet, and I think it's a bit expensive, and for the benefits, especially in our cash-constrained environment, probably not the best option. You can also look at the prostatic urethra, which both CAT scan and MRI, which I'm going to mention just now, cannot help you. And of course, there's an examination under anesthesia. If you can feel a mass, you know there's a cancer there that's muscle invasive. But even when we do all of our TURBTs, whether you do it on block, or you're using blue light, or you're using laser, or whatever, we still often understage our patients. And that's where I think we have to remember that there are other options. VRAD system is now a big thing. There are trials, particularly from the groups in England, which are actually targeting to do aggressive therapies without getting histology. I'm not so comfortable about it, but it's an important thing to remember, particularly with the fact that we have limitations on the costs that we're doing as well. But I think it's not just about doing one or the other. We know that cystoscopy is useful, we know that VRADS is useful, but it can also help us with various things. And I think the real take-home message from this is that we don't choose one, we should do both. But again, as I'll show at the end of this, that this is one of the most expensive cancers for therapies. But if you do find muscle-invasive bladder cancer, standard of care since 2003 from SWOG 8710 was chemotherapy. You get a 5 to 10% improvement in overall survival. Not great, but better than zero. Going forward, we're now going to talk very quickly about some of the other trials that are going on to make it even more effective when we're treating our muscle-invasive bladder cancers. Coming back, we've just talked about radical prostatectomy to radiation. I think here I'm going to have to go a little bit on the radiation's benefit. We know this is all retrospective data, but the fact of the matter is that triple modality therapy, chemoradiation, and chemotherapy followed by radical cystectomy are, for our purposes, equivalent. There are reasons why you do one or the other. We know, for example, if you've got a nasty bladder that's just acting up all the time, you probably are not going to be keen on that, probably radical cystectomy. There are some that are good for both. And there are unfavorable prognostic things that happen for any type of cancer in the bladder. We have to manage this, but I think, again, this just points back to the multidisciplinary teams that we have. We have to make more effort to discuss with our colleagues. So, should we be intensifying? lots of things. I'm going to just quickly touch on adjuvant Prembo, which is, but the big one, and again, I'm being schizophrenic. I'm going to talk about the ones which are FDA approved, the big god of all of us, but I'm going to talk on some things which are not FDA approved, but are coming down the line. And the first one is going to be about the triplet therapy between PD-1 and PD-L1s with chemo for patients as neoadjuvant therapy. The Niagara trial is read out. It's now FDA approved using durvalumab plus chemotherapy. There's an issue with the trial because we know that after radical cystectomy, durvalumab was continued in the experimental arm. We're not sure whether the durvalumab before or after was the most important aspect, but the fact of the matter, it is now approved, and this is probably the now standard of care for the majority of patients with muscle-invasive bladder cancer. Cost, we'll come to that just now. There is a survival benefit, of course, otherwise it wouldn't have been approved. And there's so many other trials on the way down the line using all sorts of things from the cisplatin eligible, ineligible, all of these things. But the fact of the matter is that the outcomes are at least equivalent to chemotherapy alone and probably better for the vast majority of these patients. Adjuvant nivolumab is now also FDA approved for patients with high risk. After you've done the patients, you found that there's still some residual tumor. Again, you're looking at about 15% improvement for the patients who are on the experimental arm. Is that sufficient? Probably for registration it is, but we have to also balance that against the cost. There is a survival benefit. We know that the patients get improvements, but the point is that we have to, again, balance what we're talking about, including the toxicities and tumor-related factors, whether the acute or chronic, whether you're going to have to re-challenge the patients, and there's also what are you going to do when you get tumor recurrence, how are you going to progress from there. It's a big issue. There's a lot of factors that we have to take into account here. So now we're going schizophrenic. This is not FDA approved. We know that enfortumab vedotin, which is targeting nectin and using a monomethyl auristatin, which is like a docetaxel for my residents. It basically makes the microtubules stable. We know it's the standard of care for metastatic, for EV pembro. It's now the standard. It's better than at least 2 years improvement in survival for the patients if it's on it, but it's not approved in the perioperative area for muscle invasive, which is not metastatic. There are lots of trials ongoing. This is EV-103. It's with monotherapy with EV. There's also other trials pre-cystectomy where they're using EV Prember, which seems to have such a great outcome compared to chemotherapy. I repeat, it's not standard of care, but I suspect it's going to be once all of these trials have read out. But to be schizophrenic again, all of these great treatments are nice, but they've got toxicities. So I think we really need to de-intensify in many ways. How are we going to de-intensify? That is the question. First of all, we know that, for example, if you're using the Gauss criteria, but at least 50% of your patients who are muscle-invasive bladder cancer are not going to be eligible for cisplatin. So what are we going to be doing for these patients? Many things. One of them is that even from SEER data, we know that the majority of patients do not get their neoadjuvant chemotherapy regardless of the fact whether they're cisplatin eligible or ineligible. And this is over long periods of time that we've seen. And we know that there are adverse events from any of these treatments we're doing. Cystoscopy, not so much, but still, remember, it's there. TURBT has a bit. BCG itself has got its own issues, and Steve will be talking a little bit more about bladder preservation for patients with non-muscle invasive. Cystectomy, it's there. James, don't beat me up, but this is the data that's out there, okay? But this is adverse events. It doesn't mean about quality of life or over survival. But chemoradiation is also there, probably a little bit less than, but depending on different types of side effects. And then, of course, even just the chemotherapy alone has got its issues. And the problem is that we don't really know. There's some who need treatment but don't get benefit. How are we going to find these patients, and what are we going to be giving them? We don't know. Some of them don't need treatment at all. And then there's a small window where there's a benefit from these treatments. And right now, we're busy being like a blunderbuss. We're just shooting blindly against, hoping for the best, giving so many things to our patients. So we know many patients are ineligible. Biomarkers are a big issue, and we were, Chantal and Simon were talking about these things. The toxicity, we know there's an underutilization of bladder preservation. Again, it's not the utopia, it's something that needs to be done for some patients, but not everybody even needs further radiation. They can just leave the bladders without doing any further management. Quality of life impacts for cystectomy as well as for radiation. Adjuvant immunotherapy may be over-treating for patients, and despite this, half of our patients are still having recurrence. So we need to do better. What are we doing better? There are trials ongoing. For example, the RETAIN-1 and RETAIN-2 RETAIN trial, they're using biomarkers, ATM, RB, FANCA, ERCC2 to make decisions on whether we go for active surveillance after complete response for chemotherapy. RETAIN-2 is using not just chemotherapy, but nivolumab as well. HUSIA doesn't have any biomarkers, but what they're doing is essentially if they can get a complete clinical response, and again, the difficulty is to make that decision on whether there's a complete clinical response, whether to just monitor or to put the patient onto active therapy. So this is where we should be going, in my opinion. The cytology, I'm not convinced. There are lots of urinary biomarkers which may be helpful in the future, but I think it's really just for our preliminary assessments. Chest and pelvis, CT, excellent. Cysto, GARE. But I think where the future is, urinary tumor DNA, circulating tumor DNA, and MRI. So our radiologists, somebody was commenting that no, they're on the way out because the AI is there. But the reality is that they're getting much better at picking up things. It's not just about T1s, T2s. They have so many aspects that they can pick up on MRIs to make decisions, including checking out for necrosis, solid tumors, all of this leading to radiomics, where they can actually make a decision that this is really muscle invasive, this is a complete response for the patient. We can now make decisions on that. Nuclear medicine, also on the way up. Mike might not be coming to join us, so I'll just take a little bit on this. There are nuclear medicine trials now picking up bladder cancers using various types of gallium. And even better for some of us is using CXCR and fibroblast activating protein, targeting using lutetium to actually target the cancers as pre-cystectomy or further therapies as well. And in fact, they actually have a whole response criteria now, similar to VIRADS, which is now being validated, or it's actually been validated, to make decisions on whether we're going to continue or what your next plan is if you're looking for complete response. Simon's left, but the pathologists are also advancing, even though they're threatened by AI as well. They're not just looking at the cells anymore, because the cells don't tell us that much in some ways. If you've got a patient who's on chemotherapy, these variants that we're talking about can make a huge difference on whether the patient is going to respond or not. So we need to, again, make better decisions on what therapies we're going to do so we can de-intensify. Because we're not looking anymore just at additions. We're looking at synergy between these drugs. Because even like with Niagara trial, with durvalumab, we don't know whether it's the durvalumab that's making the difference or whether it's the chemotherapy. So what else can we do to make decisions? Our pathologists can assist us. Not just looking at the cancers, but using genomic assessments to make decisions. Incorporating EMT, myogenesis, all of these things to come up with scores that also just include the tumor microenvironment. And I think that's a big thing. For example, with the theranostics, with the fibroblast activating protein, it's not targeting the cancer, it's actually targeting the fibroblasts that are in the microenvironment, which are assisting the tumor cells. All of these things can be addressed. Again, cost is going to be an issue, but it can help us to make decisions. Because we know, for example, if you have a basal, luminal has got the best outcomes. This is all based on all of these different aspects. It's not about genetics just alone, it's genomics, RNAs, various other things. You can make a decision on your therapies, including specifying which type of treatment. For example, we know that a lot of these things, for example, Nectin, which is upregulated in most bladder cancers, if you've got fibroblast FGFR, they usually are not in the same tumors. They won't find them in the same tumors. So we can make decisions that, and if, for example, TSC, which is the T-cell to stromal equivalents or something, where you've got more T cells in your stroma than stromal cells, you're more likely to respond to immune checkpoint inhibitors. Cutting back on the different types of drugs, making it necessary for specific drugs to be targeting your specific cancer. But I think the real future is going to be in circulating tumor DNA. Picking it up, liquid biopsy, huge difference for the majority of patients. We know that there's data already out there that if you give a patient chemotherapy or whatever you're deciding, and you then get negative circulating tumor DNA and urinary DNA, which is not as big as circulating tumor DNA at the moment, but it's going to be part of the aspect, it can make a massive impact on your outcome. So should we be stopping our therapies once you've given a chemo or the chemo immunotherapy, if there's no circulating tumor DNA? There are lots of trials on that as well. And I think these are going to read out in the next 2 or 3 years, which makes our lives a lot easier. But again, we have to have access to the circulating tumor DNA. And that's going to make the difference to decide whether we're going to be doing anything further adjuvant therapy in the case of modern trial to decide whether you're going to give nivolumab post radical cystectomy. And we can't go anywhere anymore without discussing a little bit about artificial intelligence. It is here with us. Whether we like it or not, we can't really fight the fight. We must become physicians who are incorporating it. It's not going to replace us, at least not in my lifetime, which is not very long, especially with wine. But we need to remember that we have to incorporate it, and we also have to remember the medical legal issues of this. That's not my talk, but it's a big thing because at HBCSA we're having some cases already. We need to keep it in mind, but it's going to be a big thing. So future, we're going to be making much better decisions. We're going to be deciding which cancers have got a problem, what therapies we can make for these decisions, how are we going to treat the patients, how are we going to follow the patients up. Huge, and I think the future is super bright. But there's a downside, the cost. Bladder cancer has been is supposed to be the most expensive cancer that we have, and it just keeps increasing in costs. And it's not just the costs of the patient for the suppliers or the medical schemes. It's also about trying to pick the patients up earlier, because the further down the line you go, the more expensive the therapy is going to be. All of these things, I'm not going to, that will give us some insight into things like EV. I don't know, it's even more expensive than Pembrol as far as I know. They are super, we want to pick the patients up earlier, which means a social change as well. We have to start incorporating the fact, like for example, females we know are more likely to die from their bladder cancers because our GPs have not been trained enough to know that if a patient has visible hematuria, that's not just a UTI. Treating them 3 or 4 or 5 times for UTI, it causes them a problem. We need to pick up our patients earlier, treat them better. And it's not just about the therapies, it's also for the patients. Their time away, the out-of-pocket expenses that they all have. Massive amounts. A lot of our patients are poor, especially in state. Well, everyone's poor in their own way, I suppose. But the point is, it's massive. And when you consider that in cancers, up to a quarter of patients who get a diagnosis of any cancer, this is not just for bladder, will die bankrupt, leaving their children, their spouses, whatever they are, girlfriends, depending on who you are, out of pocket. I think with the girlfriend, we want to leave them out of pocket. But the point is that cost is the big thing, and we have to address this. It's not just about the funders. It's not just about the state. We have to be proactive about this. And I'd like to encourage you. We have a bladder cancer advocacy. It's run anyways, but I would like to invite everybody, when we're up and running, we're going to be doing that. It's an international thing. So hopefully this is the end, where we're going to get patient preferences, comorbidities, efficacy, survival, important, not the only thing, insurance, and quality of life. I think we have to remember that quality of life is the most important thing for our patients. It's not just quantity, it's quality. And I think if we can make better decisions about our patients, it'll make the difference for us. Thanks very much.